What the hell is a doctor doing talking at the State Fire Association about cutting up cars and using tools and firefighting technology? Well, here's a little bit of background on me. I am not a firefighter. That was not my background. I was EMT, police. I went to med school and just kind of kept going. My tie back with like Byron and Holmatro is I was in Indianapolis for the better part of a decade where I did my training, and good luck and timing is one of my mentors. I didn't really realize it was kind of retiring. I was kind of thinking that maybe I should take over Indianapolis for the medical direction for the Department of Public Safety there. So Indianapolis Fire and Indianapolis EMS and IndyCar was kind of a nice addition that kind of fell in my lap in about 2010. I think you'll see that the lessons learned with cars that crash at near 300 miles an hour can easily be applied to cars that crash at 30 miles an hour, and that the same techniques and the same evaluation and the same kinds of injuries exist. What we do on the IndyCar track, would you guys agree, is kind of the same thing we do on the streets of wherever we are in Colorado? Stabilize a patient. CABCs. What does CABC stand for? We're all pretty much EMTs. What does the C of ABC stand for? Cervical collar. Have we heard that before? So don't poo-poo away the cervical collar. Then what? A is what? B and C. And all right, then we can get into D and E. What are those? Disability, and what's E? Environmental factors. You know, like, does it snow in Colorado sometimes and people crash their cars? Yeah. And as you can tell, like with my accent, I'm from Texas. No, I'm from Minnesota. We'll talk a little bit more about it. But, you know, second thing, if shit's on fire, we gotta put it out, right? And sometimes those two things need to happen simultaneously. I'm very good at oil dry. They love it. You know, why is the doctor putting down oil dry and sweeping a broom? Because that's what I do at any car until somebody needs me. And then, what do we need to do? We need to get a patient out if they cannot get out themselves. Who's ever been to an IndyCar race? Usually I show some video of an IndyCar crashing at 200 miles an hour, but I think I was going to pause for a second. This was back in May. I live in Minnesota. I live in a part of rural kind of metro, like right on the edge of existence. And this was a bunch of 12 and 14-year-olds that wanted to go fast. And they were going a little too fast around the corner over a bridge on a lake. And they put their car over the edge. And we had to extricate some patients. And unfortunately, we had a 14-year-old girl in the passenger seat that couldn't feel her legs, complaining of severe back pain, couldn't move her legs, and we needed to get her out. When you guys look at this as the first scene, you can see what we did. Does anybody have a class that they've taken over and over again on how you get someone with a spinal injury that is paralyzed but not life-threatening out of the passenger seat after they put it over a bridge at 50 miles an hour and the rear tires are in the water? Is that, anybody remember that class? Okay. That's what we had. And this talks to two things that I wanted to pause at. First, Holmatro, the rescue experience, all people from IndyCar taught me everything I needed to know. We can do two things. What are the two modes when we need to get a driver out of a car? Fast and slow. So rapid release or controlled release. What is a rapid release? What is a, we need to get them out of the car now?
Nothing to take into consideration, just get out.
Nothing to take into consideration. So what's the scenario? Just give me one.
Car's on fire.
Car's on fire, patient is unconscious. Rapid or controlled release? Okay. Car's on its side, we got all the other kids out that are critical, and you got one that's talking to you, breathing, has good O2 saturation, has a good pulse, won't move because she knows she's paralyzed, and she's stuck on that passenger seat down on the ground. Rapid or controlled? Okay. It took us almost 48 minutes to get her out, but we went slow and methodical. And when you're out there, remember that even in rapid, slow is fast. I know that's a cliche term, but this is one of those things where I couldn't thank Holmatro and the IndyCar safety team and every firefighter that ever taught me everything I know, where I'm just a product of experience of 10 years of teaching rescue experience with Holmatro and Keynote, that I had all the skills that you guys are going to get out there today from really good instructors on how to get this girl out. So that's setting the stage for what we're going to talk about. All right, IndyCar. Out on the streets, when you guys unload, so the ladders there, the engines there, maybe light extrication, heavies, whatever you guys got set up, your rescues. Does anybody have a code system at which you can quickly, as the first or the second into the hot zone, quickly tell the captain or the battalion chief or whoever's your commanding officer what you have and how sick they are? No. I don't know really any place that does it. So something to take away, something to think about when you go back to your departments is, should you have a code system for extrication? Because IndyCar does. Twofold, as you can imagine, it's a little hard to talk to each other with IndyCar going around the track, very loud, maybe not always the scenario we are in the streets. But the other is multiple patients, multiple cars, we need a system. One, they see a finger go up, everybody goes into controlled release, everything's okay, the driver can probably self-extricate. 2, we got an injury, probably need some help. 3, we're gonna extricate. Somebody still can't tell me why we don't have a goddamn 4. And 5, we're dead and we're in a rapid scenario, okay? So something maybe to think about when you take that, because that's something that we have at IndyCar. It's easy to do, and it works. Works over and over and over again for years and years. So maybe a key takeaway is, should you talk about having a code system with your commanding officers? You guys get into a crash, no matter how bad it looks, and let's say we got to pop a door, let's say we got to spread a door, let's say we got to cut a door off. Does everybody just get out the backboard inherently and say the patient's coming out on the backboard and we're putting them over on the stretcher? Or do your departments allow you to cut up a car and then ask the patient before you do anything else, hey, now that we cut up the car and released maybe the dashboard off your knees a little bit, can you stand up? Dude, is that something that's reasonable? We've been doing that at IndyCar for a long time, no matter how. Let the driver self-assess. That's a great part too that maybe you could take back. So we have all kinds of assignments on the IndyCar. You know, we drive Chevy pickup trucks now. We've got all kinds of pickup trucks, but basically front passenger seat is like where I sit. So that's your paramedic or your primary healthcare provider, your EMS essentially. Left rear seat is firefighter 2. They're gonna hop back up on the cowl. They're gonna, and we're going into like code 05 or code 03. Like we're taking the patient out. The patient isn't able to self-assess. They can't get themselves out. Driver would be essentially what your commanding officer is. So usually the shotgun seat, you know, in this scenario, they drive so that they have both the truck and the command. And then right rear seat is there. And what we do is we kind of, as we sit in that truck, as we run up to the vehicles, the paramedic goes first, as fast as they can, get to the driver, assess, or let the driver tell you what their self-assessment is. As you can imagine, race car drivers are a little bit of professional crash victims, right? Going fast is fun, you push the limits, you crash. That's what these guys do. So paramedic gets there first, sees what the assessment is, and then firefighter 1, firefighter 2 usually have fire suppression responsibilities, but if we go into our circle of care or we form a circle around the driver, you'll quickly see that firefighter 2 comes up on the cowl, paramedic, so they can assess. Crew lead will go on left shoulder, and the firefighter 1 from the back seat will go on right shoulder. We kind of form this circle around the patient. Is this starting to look sort of like something we might do in a car? You might have somebody in the back seat saying, let's get this. You might have someone in the front seat, might have the patient covered. This is starting to look a lot like what we do. So, no matter where I am, if I'm in my Interceptor Explorer and I'm responding on a scene at Prior Lake where they went over to that, or I'm on the IndyCar track, I'm a doctor, but when it all comes back to it, I am an EMT. Everything I do is back to EMT. I did it, that's how I learned, just like you guys in here. So don't think that it isn't a good training, that if you have limited skills. In trauma, EMT is it. That's what you need, and that's how we function on the track. I'm not doing fancy doctor shit on the track, probably not until at least we get them out and we get them in the ambulance or headed to a hospital. We're doing the basics, the CABCs. BLS airway support, we got MP airways, OP airways. One of the interesting things that we have, you know, and anybody that does like sports, you know, if you get tagged for the sideline for your kids, or if you work at like a local dirt track or whatever, or ATV in, or, you know, you got buddies that have a whole bunch up here, hold this, watch, you know, kind of situations is, if you got the helmets and you got the hoops, that can be an impairment if we're trying to extricate somebody or we can't get it off. And one of the interesting things we do is that we call it the trumpet airway device, but we take a nasal trumpet, so you know, the nasal pharyngeal airway with the big saucer on the end, and we actually put a pediatric endotracheal tube inside of it, and you can go through a mask, and it's kind of a blind way to get an airway on someone deeper than just what you can get with an NP or OP airway. It's one of the unique things we do at IndyCar that I haven't really seen anywhere else. So that's something different we do. We have bag valve masks, and a lot of times, unless you have had that unique scenario where you guys went for ice cream at McDonald's and some fries in the engine, and you watch two people T-bone each other right in front of you, a lot of the times the big difference for us in IndyCar is that we are catching up to the vehicle responding while the car is still moving. That doesn't happen to us a lot on the streets. You guys agree? Has anybody been there right when it happens? Okay, what did they look like? What did the patients look like?
Shocked.
Yeah, they look like shit. If anybody, like, to tell you honestly, most of the time we have like that 4 to 7 minute response time, maybe a little bit shorter, maybe a little bit less. You'd be surprised how much like the human body goes into like blue screen mode with the computer, kind of has the circle of death, takes a little time to restart. So that if you see that, you need to give drivers sometimes a little bit of spontaneous time to recover, because if you're there right when it happens, they look like they're dead. And then like in 3 to 5 minutes, they kind of have to reset. And that's what we're afforded a lot of times on the street. And something that IndyCar afforded me is you got used to seeing what people really look like when they take a big hit right away. And it's amazing how a body can take a big hit like that and then give them time to spontaneously recover. So another takeaway is if you're there right when it happens, don't be surprised if the patient looks like shit. But slow down, CADCs, get it in place, get some airway on. Don't give them a little bit of time to spontaneously recover unless you see like parts missing, that side, right? Like arm is over there, patient looks like shit in here, get them out, they need to get into the trauma center. A graphic here on how we get them out, just to show you it's kind of unique, you know, the cockpits. And then if you've watched IndyCar in the recent years, is after what happened in Pocono, now there's almost the windows that almost complicate things a little bit more. But paramedic in front, firefighter 2, and then we get our ambulance crews in, and basically we do a movement where we have, anybody still have headboards?
Yeah.
Some of us, you know, I think they're a great tool. They kind of like fell away. Some people have them, some don't. But what we have is basically carbon fiber built by the manufacturer of the car's headboards. They can really slide down in that cockpit, and then we allow them to strap in. And that's kind of our first movement. We're able to headboard them out and up over to the side of the pod, and then we get them onto the backboard, and away we go. When we get to a car crash, we have backboards and seat collars and all this stuff. Why don't we just tear everybody out of a car? Spine. I heard spine, right? We've all been taught to fear the spine. Is that a safe statement? All right. How often have you actually extricated someone that you definitely knew, without a doubt, has severe spinal injury, and they needed to go to the neurosurgeons at the trauma center and go to the operator? How often do you feel like that is? I got one. I wasn't sure if you didn't get one. I had to double check. I got one. Well, would it be safe to say these are pretty onesie, twosies, maybe not too many in your career? So we do something a whole lot for something that doesn't happen very often in our career. So let's just talk a little bit about this. Now, when we started this talk, this was a little bit more controversial, because at the time when we started doing some of this research in racing that we're going to talk about, people were real uncomfortable about letting drivers get out of cars. As you can imagine, like when we go to a trauma center with an IndyCar driver, and the EMS report is, this is a race car driver that crashed at 232 miles an hour. What do you think the trauma center does? Yeah, they shit themselves, right? Like, who crashes at 232 miles an hour? So they're a little uncomfortable with like those people not being on backboards and with seat collars on. You can imagine, right? But at the time too, when we were giving this talk, that was kind of an uncomfortable place to be on the streets. Now, how many at your departments have like selective spinal immobilization? That's a term that basically says you guys get to pick and choose who gets a seat collar or backboard. We've got protocols for that, hopefully medical directors. But sometimes I think it's good, because every time we go to extricate somebody, this has been burned into our brain. let's focus a little bit on why we do what we do. And I want you guys, when you're out there, to think about the rapid versus controlled release. Byron, are they doing a rapid controlled release here? Yeah, or at least talk about it with them, because that's the importance of going fast and slowing down. There's different techniques. The tools are a little bit different, and what you can get away with, you know, as the risk benefits quite a bit different. So talk through that with your instructors. But let's go through what this all means. So you can always count on war to make emergency medicine and trauma care better. Is that safe to say, especially for, I don't know if we got some Vietnam era pride, you know, might remember a little bit of that in the back, but I think the majority of us in here probably remember a lot of war in the Middle East in our time frame, and that like tourniquets, TCCC, you know, stop the bleed. This is all stuff that's come out of war in the recent last 2 decades. But let's rewind this whole fear of spinal injuries goes back to the Vietnam era. And there's some history here that's really important, is that how the military started to set up basically EMS or trauma operations in Vietnam started to really change the landscape of how we all do our job when we're doing EMS response, not as much fire response. And one of the things that became very clear is how they were doing, you know, the Korea War too, is how they were doing kind of membership MASH. That was like the first step. The Vietnam was the next step, of where you brought a corpsman or a paramedic essentially to the patient instead of bringing the patient to the healthcare or to the trauma surgeon or whatever. And helicopters were involved and so forth. And what they started to realize is the car crashes on the Dwight D. Eisenhower interstate system in the United States were more deadly in a car crash than when you got injured on the battlefields in Vietnam. The survival rates were mismatched. So things started to change rapidly in this time frame, and the textbooks started to catch up on this. And basically, the reason we all fear the spine is because it was somebody's good idea in that transformation on the interstate highway systems that a doctrine was basically written in the textbook that said no patient should be extricated from a crash field without spinal mobilization. That's really how this all started. And it took almost 40 to 50 years to unravel it with research to really understand what it means. So, if you look up what's an unstable spinal injury, you get a whole bunch of stuff on Google. Be careful what you search for on Google, right? But this one's pretty safe. What do you think is an unstable spine injury? Like if you had to teach somebody, so you got somebody new on your crew, new EMT, you're going to come back from this class and you want to teach it to somebody back at your station. What's your gut check? What's an unstable spine injury? Make some guesses in the car.
Probably patient presentation.
Okay, in which way?
Say deficits,
Deficit?
pain.
Like pain out of proportion? Okay. Numbness, a loss of sensation. Pupil response, yeah. Neurologic deficit, maybe that. There's just something that says, I better put a C-collar backward on this person because I am very uncomfortable with how they look or how they're presented, right? Let's get into a little bit of what it really means. So this is a picture of your spine. So if you remember back to whatever kind of anatomy and physiology you can pull out of your brain, we've got our vertebras, which are our bones. We got the shock absorbers, which are the discs in between them, and they stack on top of one another. And this is that spinous processes. So, you know, if you're doing your selective spinal mobilization and you're doing the walk the spine thing with the patient on the scene, you're sure you're not hurting? Those are the spinous processes that you're pushing on there to the left. And basically, these things are held together with big 3 bands of bungee cords or whatever parachute cord, basically big ligaments that hold these together. 1, 2, 3. You got one in front of the bones. You got one behind the bones. Your spinal cord lives right here, actual nerves. And then you got one out on those spinous processes that you push on to see if people's necks hurt. And really, you can break one of the system, but this kind of 3-column concept is that if you break 2 out of the 3 of the bungee cords, however, whatever you believe in, God, nature, whatever, how we were designed is that's when you get into trouble. Because the spine will splint itself, it will save itself, it's pretty redundant, but when you get a bad injury that breaks 2 out of the 3, that's when you start to get into an unstable injury. And by unstable in the medical means if we don't do something about it, it probably will get worse. Meaning you probably need surgery or bracing or something of that nature. I think this is a really poignant example is millions of people show up in the emergency department as motor vehicle crash patients with cervical collars on, backboards on, get evaluated for spinal injuries. And I think you saw the onesie, twosies. Of those, 2 to 3% will have a spinal fracture. So out of the millions, 2 to 3% will actually have a fracture. Of those that have a fracture, most are stable. So we're getting down into the 1%, 2%. Is that kind of how you feel on the streets? We do something a whole lot for something we don't see very often. Is that safe to say? All right, so let's unravel this a little bit. Most of these are going to be in 10 to 30-year-old males. I've inspired from that group. You can imagine why, right? You got your sky zones, you got your four-wheelers, you got your bush lights, right? Most of them are male. Cervical spine, as you can imagine, is the most injured, probably because it's the most mobile, and also when you roll the four-wheeler, it's probably one that takes the first hit, or the one at the football games when you're working on the sideline that takes the first hit, right? So, what are we worried about? Why do we do all this stuff? Like if you have a patient on the scene, and their spine, let's say it's their cervical spine, you get there and they say it hurts, but they're able to move their arms and their legs, but it's really hurting. Why are we doing all this stuff? What are we afraid of happening? Yeah, make it worse. Things get worse, right? Okay, who's been doing this long enough that you were taught you can pull on the head and provide traction when you log roll or when you put on a cervical collar as much as you want? You can't hurt somebody with that. You're old, anybody else old? That was still the training for me. I'm not that old, but I've been doing EMT for a long time. That was probably the thing that was making people worse. So don't do that. For the most part, most of the injuries that got worse weren't because of EMS. We kind of probably did it right, or we chose the right people without good research telling us. Most of these were happening in the hospital, and some of these, we'll talk about nexus. If anybody ever heard of nexus criteria, you might have been taught it with your selective spinal immobilization. Most of those are out of that. So we have in their protocols where you let the patient put on the cervical collar. Why not? Anybody ever seen somebody that you knew for sure had a fracture in their cervical spine? Like you knew it for sure. Can anybody describe what they look like? Here's what they look like. You show up to the car crash, they're not out with the state patrol with your driver's license. They're not out of the car at all. They're in the car with dead eyes. They will not move, and the first thing they say to you is, don't you touch me. Don't touch me. Because they know something's wrong. That's the awake, alert, non-intoxicated, non-multiple trauma spinal injury. Once you see it, you will never forget it. I knew it the minute that 14-year-old girl, because she did not want anybody to touch her in that car because her body knew something was wrong. Now, the other people we see are usually drunk at 3 o'clock in the morning and a piece is missing. That doesn't count to this talk, right? That's polytrauma, intoxicated, altered mental status. What is the best things to do? Put on a cervical collar, ABC, backward to the hospital. There's not much thinking to that, right? You can't evaluate someone who's intoxicated and missing pieces and their head is injured and all that, right? We're talking about the more everyday car crash like we're gonna do out here on the pad, where the cars crash, everybody's pretty awake, maybe they're on their way home from work, and there's an evaluation process that can happen. So, once you see it, and they don't want you to touch them, guess what? If you really want to limit motion to the cervical spine, meaning you don't want to cause a worsening injury, researchers told us that if you talk the patient through how to help you put on the cervical collar, it actually has the least motion to the spine and probably is the safest thing for the patient. So maybe something to go back and talk about with your training chief and your medical directors is, should you allow a patient-assisted seat collar application? Okay. What really changed in my time frame here in medicine was in the 2000s is that we went from like the standing takedown. You guys remember those? That they are exchanging information or they're with the state patrol and they were in a car crash and all of a sudden like somebody puts their hand up and it's like, yeah, my back hurts a little bit. And before you know it, you took a walking, talking patient, put a seat collar on them, put them on a backward, laid them down, and took them from being walking, talking to immobilized. Like how dumb was that we were doing that? And really the practice things have changed. And a lot of this is like all of the emergency medicine, trauma surgeons, neurosurgery, and orthopedics. That's kind of who owns all of this stuff. Like orthopedic surgeons do spinal surgery, neurosurgeons do spinal surgery, trauma surgeons have to take care of the patients, emergency medicine doctors have to take care of the patients. So some takeaways that this Oswald guy is on New Mexico cut out this way, I thought were very well played back in the 2000s, and I think that they really play today, even beyond morbid progressions. Is it safe to say his point number one is correct? Millions of people will be evaluated. 1% will probably have something wrong. Yes. Patients, we just learned about the 3-column thing. We learned about when they're not intoxicated, not missing parts, and they're severely injured where you can't even evaluate them. And people that have seen it, they will splint themselves. Your body won't let itself paralyze itself as long as it knows what's going on. If you're hammered, it doesn't know what's going on. But if you're awake like all of us in here, some of us are awake. Like it's just pretty much impossible for your body to hurt itself. It will stabilize itself, at least in the short term. The ones that are completely unstable, so like we get the questions all the time, is what about the 30-06 gunshot wound through the neck? Name anything any human could ever do to reproduce that much injury into the neck that's going to make it worse. Can anybody? No, you can't reproduce it. So the ones that are unstable, the energy that caused that injury is so beyond any patient movement that you're going to be able to do. It's probably already as bad as it's going to get or worse. You're not probably going to make it worse. And that there is side effects to treatment. So some of the big takeaways is some of this stuff like log rolling, we'll talk a little bit about this. It maybe makes us feel good. It might be the standard of care or the regional expectation. But in all honesty, this really doesn't immobilize the spine. Neither does it backward. Think about it. Is anybody's spine completely flat? Like if it was, then we'd all sleep on backwards because it would feel great, right? I don't know. Anybody got a backward recliner at their station? No, stupid, right? It's not comfortable. What's the most comfortable supportive thing that we probably have out in the streets for the spine? Yeah, the mattress and the structure, right? It conforms to the spine. So I think that one of the things here is reducing visible movement, all the mechanical work, all these backwards and things is, we'll probably get to the point here that some of these joint position statements is, especially when we're out on the pad, backwards are an extrication tool. They are not a spinal immobilization tool. Is that a safe statement in this room? Cervical collars might reduce movement. I'll give those their moment. More than anything, they might remind you and the patient until we get this figured out, how much you don't be doing this. Right? Is that safe to say? The other thing they're really good for, especially pediatric patients that need an airway, and sometimes adult patients that are, cardiac arrest, is you can put those on there. It keeps your eye gel, your supraglottic, your king, whatever you put in there, the endotracheal tube that the medics put in there. So it has uses outside of spinal mobilization and trauma. But let's say that at least the cervical collar reminds people not to move. The backward is an extrication tool. Maybe that's where we should live. All right, let's get back to the IndyCar stuff, because IndyCar is kind of sexy sometimes. So, most of these people are in their 20s and 30s. Most of them are professional race car drivers, which I would argue really means that they're professional car crash victims. We go to trauma centers, they're going fast, they're alert and oriented. They have isolated midline, thoracic back pain, very possible. That's a very common injury in any car when these cars go up in the air and they come down. They get the thoracic spine when they do that. We've tried to build some safety in there, but that's where they get it. It's kind of a weird injury. You don't get that much on the streets. Anybody know what a pan scan is? Ever heard that term before? Ever gone with the trauma team or gone with the ambulance and they say, I want to do a pan scan? You were kind of whispering something.
Is it like a county MRI?
Yeah, well, it's a CT scan, and essentially what happens is that most of us, if we get a bad car crash, bad side-by-side crash, whatever it is, you know, so you fall off rock climbing, you might get one of these in your life, and it's like, you're really messed up, we gotta figure out what's wrong with you. They usually do a CAT scan in your brain. I should say. So CAT scan in your brain, CAT scan in your neck, CAT scan of your chest, abdomen, pelvis. So basically you get like, put through the CT scanner like a conveyor belt and kind of come out the other end and see what's in there, see what's going on. We talked about injuries, so let's say any car is no different than streets. What's the percent chance that he or she, this driver, has an injury that is unstable? Yeah, 1 to 2%. 2 to 3% they might have a fracture. 1 to 2% maybe actually need something done about it. Anybody know anybody that has to get a lot of x-rays or maybe has like a chronic medical condition where the doctors have said, hey, make sure when you go into the ER, when you go to your doctor, try not to get so many CAT scans. Anybody ever heard that before? Because CAT scans use radiation just like x-rays, and there is a radiation effect. So they actually put something in the paper which I found interesting, and I've seen this in other places, is that they are telling the patients, and they've made basically public announcements that when you're in a car crash, we're going to take you off backwards and put them on your cots. So I mean, something to think about if you're doing your community outreach and you're talking about the tools on the trucks, you might want to say that, hey, this is an extrication tool, but we are going to make you more comfortable when you get off of this and we put you on the cot on the ambulance. We actually did some research on this stuff because most normal people, and how many times do we get a 911 call for a normal person? Yeah, you know, it's like, that's kind of an oxymoron in our world, but I think they get lost in the normal. Is that most people in the United States will only dial 911 for a medical emergency 1 to 2 times on average in their lifetime. I know we all know people that call 1 to 2 times a week, month, you know, they're on the Platinum Medallion EMS VIP Lounge program, right? But those aside, it's very uncommon for us. But for some of these more higher risk individuals, so if you race power boats like I saw in Chad picture there, or you race cars, there's a consequence. And maybe if you get CAT scans all the time because you have Crohn's disease in your abdomen and it's just something that happens, there is a consequence to all this. But what we wanted to see is, could you safely self-extricate out of any cars without injuries? We're not going to get big into this research, but what's interesting is we had a lot of incidents in a few-year time period which we tracked all these 456 crash incidents. 321 we excluded because basically the drivers, like I said, are professional crash victims. They know when they're okay. Visor comes up, wheel unclipped, up on the dash, pull their belts off, hold comms in the water and whatever else they got hooked up for their own comfort. Stand up and get out. That's a pretty normal for us. When the driver's visor isn't up and they haven't started getting themselves up, that's when we kind of go a little bit more into go mode. So these 135, we were in go mode. Once we got there, we formed that kind of circle of care that I showed you. You know, we're all 3 or 4 of us around there. We're evaluating, let himself evaluate. We let him self-extricate. We had some spinal injuries. We extricated, as you can see, very few thankfully need extrication by us. And we had some spinal injuries. The ones that we let self-extricate or basically self-assess, like they do shit on the streets, as long as they weren't intoxicated, most security car drivers aren't drunk driving out on the track, because that's safe to say probably. When they're not multiply injured. That what we found is that if you have a good selective spinal immobilization and self-assessment program, and maybe you have that out on the streets, you're probably going to miss 0% of unstable spinal injuries that is going to get worse if neurosurgery doesn't do something about that. The average atomic bomb survivor, millisieverts is just like, think of it like watts, volts, amps, just a way of measuring something age. You know, the survivors had an average 29 millisieverts. Until we got better about pan scans and stuff, that CT head, cervical spine, chest, abdomen, pelvis, they were getting 25 millisieverts. Do you see maybe that there's a problem here if we keep pan scanning everybody over and over again for a spinal injury that only 1% of people might have? So this is where we're really driving is, this is the cause and effect of how much power you guys have on the streets. Because if your gut check isn't in play, and you put everybody in a seat collar, everybody on the back door, you throw them in the ambulance, and you leave them packaged like that, what signal does that send to the trauma center? They're hurt. They're hurt. Triage bias. You just did a huge triage bias that you made somebody who maybe wasn't as hurt as they should be without thinking through it, look very hurt to the trauma center, and that they're going to get more done to them than maybe they need to. Let's go the other way. You did let the driver do a self-assessment, maybe you let them help self-apply a cervical collar, and you have them sitting up on the cot when they come into the emergency department. What is that set up for? Is that a hand scan, do you think? CT head, neck, chest, abdomen, pelvis? Probably not. All of a sudden the signal is, oh, that person looks pretty good. They must have something going on in their cervical spine because they have a seat collar on, right? Don't forget that power you guys have when you send patients to the emergency department. And that's the important in this. So what if we triage biased, meaning we left them all packaged, maybe because we had to, but maybe sometimes because the local crews or the local EMS or the local physicians were with it. They got pan scans and they got a whole lot more radiation. And just to keep it in kind of perspective is, I don't expect anybody to know what millisieverts are or REMs or any of that stuff, but here's where we live, like a chest x-ray, the equivalent of doses here. And this is back with a little bit older CT technology, it hasn't been updated, but you guys agree that maybe there's a problem here, a side effect of full spinal immobilization when not needed? Like, every time I go to the ER, I don't want 400 chest x-rays, right? Like that's a lot. So, what are we really getting after here is, we gotta do the right thing, we gotta think it through, but we are gonna evaluate a whole lot more people that are ever gonna really have a bad injury unless they're injury. And remember the power that you have in raging about it on scene. This isn't a stop thinking moment. This is a really think it through moment with your team and deciding on what happens. And think that through when you're out there on the scenarios. Now it's hard to, right? Because everybody wants to get tool time. Who doesn't want tool time, right? Like those rescue experiences like this, it's awesome, right? Like 2 to 3 days of 40 to 60 cars a day, like you can't get that experience anywhere else, right? It's amazing. So enjoy the tool time, but think through it maybe when you're going through the scenarios about what would be rapid, what would be controlled, what would need full evaluation in the car versus what can just be let's cut it out and let's do a self-assessment on the driver or something. So that's really where we went with the IndyCar. So, you know, anybody ever gone to the ER with the ambulance or work on the ambulance and ever had the ER second guess anything you've done? Really? That's happened? The nurses had a snark or remark when you left about how great you are? Okay. So you're like, well, if I don't put the seat collar on, I don't put the backward on, they're gonna light me up in the ER, and then, you know, it's gonna be a negative experience. They're gonna be yelling at me that I don't know what I'm doing. A little bit of research on that. Guess what? If you do this well, with good protocols, with hopefully a physician and training chief that really makes sure that everybody understands this, there was good research that 101 patients came through the emergency department in this quality assurance initiative where the ER said, we don't know what the hell you're doing. We're gonna put a seat collar on, a backward on, and then we're gonna go searching for an injury that you didn't think was there. And what we found in this research was that if we do it right and you trust your gut and you think this through, EMS can miss 0 patients. 0 patients were missed in this study, of which they showed up at the ER, they applied a C-collar, they applied backward, and then went down that pathway. So just remember that power you have and then what you do matters, and that you can be very good at this, even better than the ER, and that's really important. Nexus criteria, we said something about that. Anybody kind of know what that is? Anybody off the top of their head? Okay. Here's the long and short of it. It's not so important on the street, but it's important to always know where stuff came from. There was a study done, and it was in the US, and it was trying to figure out who could go with or without a cervical collar, maybe spinal immobilization. It had like 36,000 plus patients enrolled in it. And what they did was try to figure out what is the criteria that could be used to evaluate patients, and if this doesn't exist, you don't need to put a cervical collar on. So some of the things that are included are age. Anybody heard of an age at which you should or should not put on a C-collar regardless? Do you feel like a grandma that fell in the shower and was 88 years old could reliably be ruled out for a cervical spine injury if she set her neck through? No. One reason was nexus criteria. The study really only enrolled like 14-year-olds to 65-year-olds. So some of the criteria we're going to talk didn't apply to that. But let me share a story about Andrew and EMT in Putnam County, Nebraska, when I was in med school pulling call weekends at the county ambulance out of the hospital. I was young and dumb, and for some reason, I don't know why, I felt like not putting C-collars on people was like a power move or something. I don't know, like, oh, that one doesn't need a C-collar, this is dumb, let's get the ambulance and go. Anybody ever felt that way on scene? It's a good way to get yourself in freaking trouble. So we went on an 88-year-old grandma in the next town over, I think it was Ottawa, Nebraska, that had fallen in the shower and dialed 911 the next day because her neck was still hurting. She had gone to bed, she had cooked herself breakfast, she had had coffee, she was walking around, and my partner was like, well, shouldn't we just put a C-collar on her? I'm like, let's just walk her out to the truck, we'll take her over to the hospital, we'll get her documented, no big deal, right? He's like, can I just put it on there? I'm like, yeah, sure, whatever, I'll be in the truck. Do I sound like an asshole? Like an asshole partner? Yeah, I would be an asshole. So we get to the hospital, we drop her off, Dr. Jackson sees her, puts her in the CT scanner. We get a call back from Dr. Jackson as we're cleaning up, getting back in service and kind of trying to throw our lights up. Hey, I'm so glad you guys put a C-collar on that lady. She has an unstable C1, C2 fracture. Can you help us out? We're landing in a helicopter in the parking lot. I looked at my partner and I said, fucking love that. Because that would have been a great way to end your career, right? So, just think about this stuff, that there are people who need a C-collar that let your gut be the check. Old people that are complaining of neck pain and trauma probably need a C-collar. That they have old spines, they have ankylosing spondylitis, they have arthritis, the bones are brittle, osteoporosis. You've heard of all these terms. They don't fit in the rules of the healthy 14 to 65-year-olds. Okay. Let's say that that's the age criteria. What's some of the on-scene stuff? So I show up in a car crash. Yeah, I'm fine. Adrenaline's high, the pulse is high, the blood pressure's high. You'll see Andrew every time walking the spine and pushing on it real hard. What's some of the criteria here that you have to meet, the nexus criteria, that allows us to selectively not immobilize the spine? When I'm pushing down the spine, what am I looking for? Yeah, midline cervical tenderness. If I push on the middle and you say, ouch, that really hurts, is that someone that needs a C-collar or not? Yes, they do. If I'm pushing down the middle and they say, no, it doesn't hurt, doc, it hurts over here, what's that? Whiplash, right? Do they need a cervical collar? Maybe not. What are some of the other things that they can't have with nexus criteria? And I've heard them before, we were talking about. Distracting injury, that's another one. Can anybody define a distracting injury? Yeah, I'd say that that's a reasonable distracting injury. Here's the funny thing about a study of 36,000 people that we all use every day, no matter if we know it or not. Nexus criteria changed everything that we do. They never define distracting injury. So here's my distracting injury. Anybody ever taken care of someone that has a boo-boo on their toe and they're screaming out of control and you just want to slap them? That's a distracting injury to that patient. Anybody ever taken care of a motorcycle crash that has a tib-fib bone sticking out of the skin and they're like, no, I can walk. I got this. That's probably a less distracting injury, but still a distracting injury. There's no good definition of it. You got to use your own gut check. But if there is something going on with the patient that you feel like would distract them or their body from realizing their spine is broken, that's what that is. Okay, what else? What else could we have? Bleeding isn't one of them. Intoxication is can't have an altered mental status. But so maybe if you're bleeding so badly that you're like in and out of consciousness, that wouldn't be good. And then there's kind of one other thing. What else can't we have? A neuro, yes, you can't have a neural deficit. So you can't have, oh, I can't feel my right arm, but I can feel my left. Or I'm not strong in a bicep curl on my left arm, but this one's working great. All right, so let's go through it one more time. You have to be 14 to 65 years old. You can't have any midline spinal tenderness. You can't be intoxicated or altered. You can't have a boo-boo or a really bad that's distracting you. And you can't have any neuro deficits. Does that sound like maybe some protocols you guys have been through? That's the background on that, okay? All right, so all that said and done, I just told you 65-year-olds and under to 14, there just wasn't a lot of kids in the study, that's why kids are kind of excluded from that. Maybe down to 8 years old, you can extrapolate some of this stuff. Most kids under 8 years old could not mobilize in their spine. A study came out of the Trauma Center in Iowa, which is actually a group that we work with when we goes to Des Moines for the race, is that they found, and this is like to scare you back and to really think this through, is they found about 19 to 20% of the asymptomatic group down to the age of 55 had a spinal injury that was concerning. So I'd say, once again, don't be this is the slide of don't be the Andrew Stevens asshole and be young and dumb and fighty. Is that if there is something that is just, the pain is there's something that just doesn't smell or look right, your partner wants to put on the seat collar, don't be the one that's trying to fight everybody doing the right thing, because the research has shown that we can still miss it, even though we usually don't. Okay, is that a safe statement for everybody? That's learn the lessons from me, don't learn yourself kind of thing. So there is consequences to all this. So how do we breathe our best? How do we breathe our best? Standing up, right? We can run and breathe well, trying to escape the police or a bear or a mammal trying to kill us, right? Standing up and running, okay? How do we not breathe best? Laying completely flat, needing CPAP because we have obstructive sleep apnea, right? Like that's the opposite. When we immobilize somebody with cervical collar and a long backboard, what situation are we in? Is that the best for breathing or the worst? It's the worst for breathing, so that's something you need to consider with the risk benefits of all this as well. Anybody been the dummy that has to do the longboard over and over again for training or skills nights or drills? Okay. Think about what that feels like. Think about you're in rural Colorado and that the local volunteer service puts on the spinal collar and the spinal backboard, and that you are paralyzed from your butt down and you can't feel anything, but that pain of having to lay there with your pelvis and your heels on that backboard, and a helicopter has to come. So let's say that takes 32 an hour. Then you gotta fly back to Denver to the trauma center. Let's say that takes another hour. Let's say you're laying in the ER trying to get evaluated, but before you know it, you've been on that damn backboard for 2 or 3 hours. Not an uncommon thing in the US, especially with more rural trauma. It really breaks down the skin. These people that unfortunately end up like in rehab that are paraplegic, quadriplegics, they end up with horrible ulcers on their skin because of these back ones. So there is something to think about there, is you don't want an infection or a secondary thing to happen to them there. So let's get this over with. So we go with IndyCar, you go with your patients, you triage bias them. They got a seat collar on a backward. They're going to get pan scanned. There is a radiation risk. Is there having tissue breakdown? Do you want to be an atomic bomb survivor or your family members and have these repeated risks and start to get a higher risk of cancer than you do of a spinal injury? No. But remember that in IndyCar, out on the streets, the age, the nexus criteria is be careful about it. Think it through. This isn't a time to turn off the brain. And if your gut's telling you to immobilize, it's fine. Let's do it. Blood abdominal trauma. It's what we do every day. Why is this and the organs in here? What is going on? Are they big or small? There you go. They're big. What in cars usually impacts this area of our trunk? Steering wheel, seat belts. Also, anybody that's been in a car crash with all the good restraints, any of that stuff, if you rolled anything, it's kind of like being thrown at a dryer or a washing machine. You'd be surprised what you get hit with and where. 90% of patients that are alert, that are in severe trauma, that are saying, my belly hurts on scene, we're going to find something wrong with them. So just like how we talked about, we're going to evaluate a whole lot of patients for spinal injury, but we're not going to find a whole lot of something. You show up to somebody that's in a bad car crash, and they're sitting there like this, and their belly's hurting, and maybe they have a sign across here, what do we call that? Seatbelt sign, so they already got a bruise. We're going to find something wrong with them in the emergency department. Anybody know what that is?
Internal bleeding.
Maybe, yeah, internal bleeding. Anybody know what? Like, this is one of those don't Google it word things, but that's a belly button. So that's like kind of what a classic maybe seatbelt sign would be across the lower abdomen, where maybe it's not a newer car, doesn't have all the great restraints, supplementals, but they got a real good hit before either the retraction device or it could lock in place. So, seatbelt sign, no doubt, you can get them up here on the clavicles too. Anybody seen those? Yeah. All right. The ones down low, and you see that, it is an ominous sign. You are going to find something wrong. Usually you're going to have small bowel, third of them will have some type of mesenteric injury. So the mesentery is what connects your bowel to the body. It has the nerves, it has the blood vessels. It can get hurt very easily because all of this stuff is flying around on the inside. And when a car stops, what happens to the body? It wants to keep going, right? Like physics 101. Well, it wants to keep going and it stops, and then any organs that are free floating want to keep going too, and you start to get injury. So, for all the stuff we just talked about that we do every day in a worry of we're going to make a spinal injury worse or they're going to have one, we're like at the 1%. Now let's get into what we should really be worrying about, is that almost a third of the patients that have seatbelt injury, abdominal pain, or a sign on them, they're going to have something wrong on the inside. What does this look like? What are these? Vertebra. What runs right here? These are the spinous processes that we see there. Arrows usually point to something good or bad. Anybody see kind of what we're seeing here? It's called a chance fracture. It's just a name for it. But if you see that lap belt sign, and they're complaining of back pain as well, there's a very high likelihood that because they slapped so hard down that they compressed the spine on the front and broke it. They extended the spine on the back and broke it. And if they break 2 out of 3, what does this turn into? An unstable injury in their spine. So before you know it, they probably got internal injuries in their abdomen. And we can't forget that if we see that lap belt sign, to not forget everything we just talked about in the last lecture, that they might have a spinal injury as well. What about if the belly's getting big on you? Any type of distension of the belly where if they look down or you're looking down, That's not what my belly looked like when I got in the car. This is also a very bad sign. This could be air, blood. How much blood does that 5'10", if that's what it is, 70 kilo adult have in them? How much is a full tank of blood? How much full gas tank full of blood? Usually somewhere in the 6 to 8 liter range is a pretty good guess, all right? So if the belly starts getting big and it takes 2 liters, how much are we starting to lose out of our gas tank? Like a third. We're getting there maybe. Now, if we have a trauma index, that's where the heart rate starts to become higher than the systolic blood pressure. If you start to see the belly getting large, and you start to see the heart rate getting higher than the systolic blood pressure, what kind of mode are we going into? Rapid, right? Are we going to worry about a spinal injury in that case? Probably not after what we just learned, right? And that's like, I always have all of our guys and gals backs in Minnesota that I'm medical director of. If you make the decision that you need to rip somebody out of a car, I will back you up because I trust that you made that decision, because the risk of the spine injury is very small. The risk of dying because you were dying in the car and we need to get you out and we need to get you to a trauma center is, the benefits of that is very high. So think through that again in your scenario. Hey, voicing a code system. Remember we talked about that? That might be something to bring back to your leadership. And with that, always saying what mode we're in. Because I see it all the time. We do these rapid control releases. You'll get out on the path, and everybody, every time, if you don't think this through and you haven't seen the mistakes enough times or you made them yourself, want to go right to the thing that is the most broken on the car, get the tools out and try to start fixing or unbreaking that thing. Not thinking through that if we need to get this patient out quickly, maybe tools aren't the quickest way. Have we checked the other doors? Most doors can look real bad on the inside, but with the pins and the engineering that's in there, always got to check the interior handle. You have no idea how many times I've seen tools coming off with hoses from different manufacturers. It doesn't matter. And I'm like, stop. Open the door. Cars are really just beer cans and pop cans. And when they crush down on the victim. But to get the victim out, you don't need to put the pop can back to perfectly where it was. You'd be surprised how little it takes to get the patient out. You don't need to do a dash spread 14 inches to get the patient out, especially when you need to get them out quick. You need 1 inch, 2 inches. And that's where like slow is fast, really thinking 360 on the scene, having a code system so the whole team knows, are we going fast or can we slow down, and then making sure that the patient is properly assessed.